The first speaker is, I think it is Dr. Raba Thapa. She is talking on telemedicine and global ophthalmology.
Very good morning. I am very grateful to Professor Dr. Azad sir for providing me this opportunity to present on this very important topic today. So I do not have any conflict of interest.
And Prashant, will you join me here?
And telemedicine and global ophthalmology are the very important components of ophthalmic education. Telemedicine, it deals more with the remote healthcare, while the global ophthalmology, it deals about the global challenges of eye health, including prevention, treatment, and access to care. And ophthalmic education is very important to provide the knowledge and training that is required for the diagnosis, treatment, prevention of disease, and it encompasses both the medical and surgical aspect of the eye. As we know, the ophthalmic education includes both the academic and also the non-academic degrees, and this ophthalmic education helps for the better surgical outcome and also the introduction of new procedures and technique to access for cutting-edge research, to refresh on best practice, so on and so forth. There are many key areas of ophthalmic education, like it helps in the global shortage of ophthalmologists, where there is a very high risk, a high ratio of ophthalmologist patient ratio in developing countries, that with the ophthalmic education, it can minimize this ratio. It helps in the standardized training and knowledge sharing to ensure for the quality education. It helps to enhance the technology for education and prevention of avoidable blindness by various training modalities, and with the international collaboration for exposure on good practices. So coming to the telemedicine, telemedicine is the technology use of electronic information and communication to ensure the health care when the two participants are in distance. So sometimes the telehealth can be used synonymously with telemedicine. Telemedicine basically, it deals about the remote clinical service, while telehealth we understand for non-clinical service like training, CME programs, or some kind of administrative meetings. With the telemedicine, it helps in the remote clinical service, both for the diagnosis and monitoring, especially to reduce the gaps in areas like rural setting, where there is lack of transportation, lack of mobility, in outbreaks like in COVID, like that. And it helps in the various teaching learning activities like for the distance learning, supervision and monitoring, online information of health data, likewise the system integration, video conference, robotic surgery, like that. So it has a very wide areas in the application. There are various types of telemedicine, like it can be a real-time or store and forward, it can be a remote patient monitoring, mobile health, or telehome care. However, the most important and commonly used is the real-time one. There is a two-way audio and video conversation with the patient and doctors, and it is the most effective, but the limitation is high-speed internet is required. The second one is store and forward. It is also very important kind of modality, and here the internet can be a slower speed, and with the remote patient monitoring, these are very new modality where it especially useful for the chronic conditions to reduce the hospital admissions and readmission, like that. And mobile health are very commonly used nowadays. The devices like smartphones, smartwatch, and tablets, they are very useful tools. They are convenient for the patient. And telehome care service is also provided through the telemedicine. These can help for reduce the hospital visit, readmission, and very convenient for the patient. So coming to the teleophthalmology has revolutionized the eye care through the use of technology. It has enhanced the access to the rural areas. It is very cost-effective, time efficiency, and also the introduction of artificial intelligence has reduced the time for screening of very imported diseases like diabetic retinopathy. So like in other telemedicine, the teleophthalmology we can use like remote consultations using live or cloud-based technique, or teleoptometry is also important nowadays for the screening of refractive error and vision. With the high-speed technology like fundus camera, OCT, or wearable devices like smart glass or telecommunication platform, video calls, technology of telemedicine has been enhanced nowadays, and there are many benefits as we already discussed, like for the remote diagnosis and monitoring of the disease, and which is very convenient for the patient, and also the cost effectivity and scalability of the program, and also the education and training. These are the benefits of the telemedicine. However, there are some challenges like limited technology access, especially in the rural areas, data privacy concern for the patient, and also it needs training and familiarity with the system that may be difficult in the rural areas. So the future of teleophthalmology is very bright with the integration of artificial intelligence, which has already been FDA approved in case of DR screening, and there are many AI development, expansion of portable devices in the rural areas, and global reach programs, especially in the low middle income countries. We know from the Asia Pacific region, we have that AI development in DR screening from the SNEC with the help of IRIS. And to conclude this, telemedicine is very important tool to improve the eye health by making ophthalmology service, especially in the to all the areas, and we have to encourage the adoption of telemedicine in various ways. The second important aspect is the global ophthalmology. It deals with the global challenges of eye health, including prevention, treatment, and access to eye care for the both medical and social aspect of ophthalmology. The main goal of global ophthalmology is to reduce the avoidable blindness and visual impairment. The key areas of global ophthalmology are the eye disease prevention and treatment, and healthcare access and equity, especially in the low middle income countries. Education and training, it helps a lot in the ophthalmic education, partnering with different hospitals from the developed and developing country, online educations, and also the technology and innovations like artificial intelligence and other techniques for the remote areas. There are various challenges globally for the low-income countries, especially like inequities in access to care, and other important challenges is growing of the aging population. This is more important in the developed country, where there is high risk of disease in case of elderly. The challenge is that there are 90% of the visually impaired people live in the low middle income countries. So this is one of the important challenge, and on the other hand, 45% of the global population lives in the rural area. In Asia Pacific region only, 50% are residing in the rural areas. The projection in the overall ratio is that still 35% will be in the rural areas. So this global ophthalmology is very, very important to access the good eye care for all. The challenges in the rural area is that there are limited eye care service in the rural areas. In combination with this, there are very difficult geographical terrain, especially like in hilly countries like Nepal, and there in the rural area, usually the socio-economic status is poor and peoples are more illiterate than in the urban areas. So these are another barriers, and other barriers are the limited financial resources, lack of awareness, and also the cultural barriers. These are more prevalent in the rural areas. So the key strategies for global ophthalmology are the eye health advocacy. This is very, very important for raising awareness and policy development, and not only development but implementation of the policy. Community-based programs to be enhanced, like outreach program, screening, and education program. The other strategies to combat these solutions will be the training of healthcare professionals. That is why we are here today. This is one of the important aspects, and telemedicine is another aspect for the global ophthalmology. There has been many efforts for the prevention of blindness as a global ophthalmology perspective, like WHO Vision 2020 program for elevation of the avoidable blindness, IAPB programs, in coordination with various organizations and country level programs, and also the national level program, like in India, Nepal, and many other countries have their own program to reduce the avoidable blindness. So as we already discussed about the innovative solutions like teleophthalmology, mobile eye clinics, artificial intelligence, and use of various portable devices, especially useful for the rural areas, are the solutions for global ophthalmology improvement. And the other are just strengthening partnership. It's not a unique, it's not a single program, but the nation should be there. Whole nation, government, NGO partnership is very, very important, and enhancement of training programs is very important. And there are certain institutions have already developed the global ophthalmology program. For example, in case of Singapore National Eye Center, Muren Eye Center, and various other institutions in the world have their own global ophthalmology division that have started their fellowship program, outreach programs, especially focused on the low middle income countries. That has helped a lot in the exchanging knowledge between the developing and developed countries. So with the development of global ophthalmology, it has many impacts like reduction in global blindness, improvement access to care with the use of mobile eye clinic, telemedicine, and global outreach programs, economic and social benefit for the patient, so that it enhances the productivity of the patient, and advancement in training. To conclude, priority on global ophthalmology, it helps to reduce the preventable blindness and visual impairment. It is very useful for building sustainable eye care system, focusing on improvement of vision-related quality of life, and achieving equity in vision for all, regardless of the location or resources. So takeaway note is that we should focus on the development of telemedicine and global ophthalmology by each institution, stakeholders, and country to avoid the blindness and equity to eye care for all, especially in the developing countries. Thank you very much.
Thank you, Dr. Rava Thapa. Thank you very much for your very illustrative presentation. I'll now ask Dr. Prashant Garg to start the interactive discussion, take some questions from the floor.
So before we begin, how many of us have used the telemedicine to deliver eye care? 4, 5. Will you like to share what you feel are the major limitation at this point of time as far as telemedicine?
This is a very good, Rupesh, this is a very good, point to discuss. Before he was asking, when she was making a presentation, just came to my mind, telemedicine we have been hearing for a long time. So, but it has not, what you can call, there's not much awareness, or there is some practicality issue are there, which is, not allowing this thing to, go all over. So we would like your opinion on that. It's a very, good question.
No, I think very practical and very good question, and I'm glad you brought it up.
Hands on mic.
No, I'll just speak.
Hands on mic, Dona.
Yeah. So basically, even before the proper telemedicine platform started, I've been doing this from 2013 onwards for various parts: Sri Lanka, Cambodia, Nepal, India, multiple places. So one positive thing is that you can connect with many people. So I used to dedicate 6 hours per week for the telemedicine related thing. But the question from the panel is, the chair is about the challenges. So number one challenge is that you don't have, so it was patient, doctor to doctor, and then there is a patient sitting there. It was never directly with the patient. So I think the people who are thinking as a doctor directly to the patient, I think it is very challenging. But I'm just talking doctor to a patient. So for me, for uveitis patient, I don't have all that information which I need to know with the patient. So idea was to educate, but you still have limited information access. So that is one thing, that incomplete information for me to make a decision. Number two, you're always little bit think about your reputation for me, or implications, if not terms of legal implication, but for me it's like if I go wrong, what it will do. And because you have limited information, because people will say, oh, you are a uveitis specialist, we thought you are established uveitis specialist. So that's a fear in your mind when you deliver because you are thinking about that and then there can be something. So these two are main: incomplete information and then bit of a comprehension.
Anybody else has thoughts?
I'm Dr. Anu. I practice in Nepal. I'm also uveitis specialist. So, as Dr. Pesha said, if it is posterior uveitis, yes, you can see some, lesions, but still, even then, you doubt whether it's an active lesion or not without evidence of FFA, all those things. But about androuveitis, you can't see cells flare and you can't see KPs through telemedicine. So it's really difficult to make out whether, diagnosis of the androuveitis is difficult. So posterior uveitis, yes, to some extent. So that's the limitation. And then you can't really talk to patients a lot about the symptoms detail.
Anyone else? Yeah, please.
Good morning, I am Dr. Ambekar. We have a very limited hours for working with this. I work in the state government medical college and we have connected district hospitals to that and we give around 1.5 hours per week to see the thing. But here, as they say, the barriers is technical club the cases and he just project and we write the advice, but we don't know what's happening to them, whether they are following or the expertise, whatever we are advised. They are not coming to us back to back and there is a follow-up, you can say is a zero. But it's a very small efforts we are making, not a full-fledged execution of this. But that's going to really help it out if you do it robustly. Thank you.
Is there any concern about the technology that is, because I think not being able to see lot of data is a limitation of the existing technology.
Just on, put that on.
Yeah, it's on.
Technology is definitely going to help us. It's a good tool to deliver the care. But we should have a complete circle on this. A network should be there completely, not then only we are coming, sitting at the one end and delivering the expertise. So we are just giving the opinion, not the care. Exactly, if you want to say. Thank you, sir.
I think all of you have expressed your, feeling and your opinion. I'm seeing the telemedicine on a very wider perspective. He talked about uveitis, she also talked about uveitis, you also talked about the government. So government was coming to my mind that time. Basically, what I'm looking at telemedicine is a wider perspective, wider approach. Basically, telemedicine is meant to go to the rural areas. Because, the primary health care, we have the primary health center in India, maybe in Nepal also, and many other countries we have, mostly in the Asian country. And to reach the population, the community, that is the point, which the telemedicine can do a lot in this area. Few institutions like his institutions, now where I am working, Akhand Jyoti, we can organize a telemedicine in our own area. But the government is silent on this. Not silent, I will say, they are sleeping on this. So, because they are not understanding the importance of telemedicine. The primary health centers are not working. I can tell you about India. Because there the doctor don't go. It's a village, and village the doctor is not going. So, telemedicine can do a lot if it is effective, and if it is practical, and as Rupesh said, and Anu also said, that you need to have the material, the data, like, for uveitis or for any other disease. You have the kind of, a protocol is there. So then it will make it easier. But to see it in the larger perspective, I think lot more has to be done in this area.
Is related to telemedicine in rural area. We got the camera, the technology, and we provided the platforms to 25 through raising donations and giving that. The problem, and I will not name those centers, it's kept in the cupboard, the camera. The handheld slit lamp also kept in the cupboard, the slit lamp anterior segment photograph. there were 3 people screened in the rural community because that drive or that incentive or the
Motivation.
practicality,
Motivation is
was
not
lacking.
there, yeah.
Then how do we make it happen? Because then we decided, okay, we need to fund the manpower also. So we funded the manpower who can do. But then that manpower was missing, and then there were no people who were coming to deliver. So in the end, when we analyzed the effectiveness of our program, in a year we were able to screen 20 people, which was not the best outcome because then it has to be connected.
So in our institute, our colleague who does work on the retinopathy of prematurity started using telehealth for ROP screening. So he built a team which was trained to take good images in neonatal clinics. So team was moving through the mobile van from NICUs to NICU, and he was sitting at a tertiary care center. And you might be knowing that the RedCam you can connect through a laptop, and this laptop on Zoom platform was able to deliver images in live, and he was able to guide technician, can you show me this image, this area, and was able to talk to the families as well. So I think that example showed us the true potential of telehealth as far as taking care right into the rural and community areas. So there is a lot of scope. I think it is a matter of how do we strengthen technology by constantly working on the technology platform. We also experimented it in home care, where our technician goes to the homes of people who cannot come to hospital, and they use devices where the examination is directly relayed to the tertiary care center, and you can look at in life what is on the slit lamp, what is on the OCT, what is on the fundus photograph, and talk to the family as well. So it's a huge scope.
Right, so we go on to the next talk, and that is by none other than Dr. Prashant Garg, who is the chief of the LV Prasad at this time. And he'll be talking about innovative curriculum development for ophthalmology in low resource setting.
So good morning, and first of all, I'd like to thank Dr. Ajad, South Asia Academy of Ophthalmology and Asia Pacific Academy of Ophthalmology for giving me this opportunity to share with you the need for creating an innovative curriculum if we want to develop not just ophthalmology but also the eye care workforce in the low resource settings. I do not have any financial disclosures to make. The objective of my talk is going to be highlighting the need for innovative dynamic curriculum, and then discuss with you some of the changes that are necessary at this point of time if we really want to create workforce which is aligned to taking eye care to all those who need it. And then I'll also briefly touch upon a more recently published monograph from World Health Organization that has really highlighted that the eye care workforce development has to be based on the competency framework rather than having a fixed curriculum and distinguishing or certifying people who pass the curriculum. I think this map is particularly very important to give you a perspective of the population and the burden of disease in the first or the upper column. And then in the second row, you will see the number of medical schools and the workforce available in different parts of the world. You will see that the areas where the burden of the disease is more, they are also the most populous part of the world as well. That means the absolute number of people suffering with diseases is going to be much, much large in those parts of the world. But unfortunately, despite having a large population, despite having the large burden of the disease, the amount of or the quantum of the workforce that is available to deal with the diseases is relatively small. You can see Africa shrunk, India shrunk. So it looks like that these nations have limited workforce, but at the same time their preparedness to bring out the workforce is also less because you are seeing less number of medical schools in these parts of the world. The same translate into the eye care. The vision impairment and blindness, both in terms of percentage of population as well as absolute number, is way high in Asian region, particularly the Southeast Asia region. If you want to look at the graph in terms of the burden of the disease and the people available to take care of this, you will see that the areas where the burden of the disease is high, the graph is skewed toward the low workforce available to deal with not just the blindness, but also if you include the number of ophthalmologists and optometrists together available to take care of that. To add to this challenge of limited availability of the workforce is the wide variability in the causes of blindness in the different parts of the world. And what we are currently doing is we are copying the curriculum from the Western world and replicating into the low and mid-income countries. And think about it, those curriculum are designed to take care of the disease that are important to them, and if you just copy paste that curriculum, you will not be able to take care of the problem which probably are unique to our region or are much more important as compared to the Western world. Let me highlight some more challenges that are there as regards the workforce. There are very low budgetary allocations for health and health education. There is lack of ability to train, retain, and appropriately use skilled workforce. Most of the time, people keep concentrating into the large urban areas where probably there are enough workforce. And where there is lack of workforce, most people do not want to go. Number 3, over a period of time, what we have done by replicating the same curriculum as taught in the Western world, we have created a mismatch between the workforce skills and the population need. We need more workforce around those who can take care of corneal abrasion in rural area if you want to tackle the corneal ulceration as a cause. But there are no workforce available in the rural areas. Number 3, there is inadequate and variable quality of competencies and care. You have RP center at one end, and there are many residency programs where the residents come out without doing cataract surgeries. They still certified ophthalmologists, but have not done any cataract surgery. How can you expect the cataract backlog to be taken care of if the curriculum are not uniform? The skills with which the graduates, the ophthalmologist graduates, are not uniform. And then we do not have a very integrated healthcare system. At primary care, there are not enough workforce. More and more people are wanting to become specialists, whereas there is only limited need of subspecialists in our community. And this was a beautiful article that was written in around 2001 or so, which highlighted that professional education has not kept pace with the growing challenges in healthcare. And this is largely because our curriculum are fragmented, outdated, and very static. If you look at what was taught to me in 1987 in ophthalmology, when I see even today, there is hardly any change in the curriculum. Whereas our priorities, our disease burden has changed drastically. So therefore, you will find that many of the graduates are ill-equipped. There is very less attention to teach them diabetic retinopathy. There is less attention to the glaucoma. Now, in that setting, when the population is aging, these diseases are becoming more important. How can you expect ophthalmologists to take care of these? So how do we address these challenges in the curriculum? And let us discuss what are the desired changes that can be. I think the curriculum typically are where the curriculum is preset. Based on that curriculum, educational objectives are created and the assessment tools are built around. What we need today is we should highlight first the healthcare needs and the health system. Based on that, we should decide on what kind of competencies the graduate should acquire to take care of those healthcare challenges. And then build curriculum as well as assessment system so that when the graduates are assessed, those competencies are definitely going to be there in them. The competency-based curriculum will allow us to adapt curriculum in the local context. Wherever certain diseases are more common, you can modulate the curriculum to ensure the graduates have those skills. It will inclusive of competencies to deal with 21st century health challenges. It will also be inclusive of primary care and will be responsive to rapidly changing knowledge and the needs. We should also consider inter and trans-professional education. Typically what happens, you have a nursing school separate, medical school separate, technician training program running separately. They never interact with each other. Let us look at why it is important to build interprofessional education. I am sure that all of you will be able to recognize this fundus photograph and think about what will it involve to take care of this patient. Is it only the retina specialist who is needed, or do we need more people to ensure that this patient gets a complete care as a human being? I think you will agree that we need to take care of the vision loss, but we also need to take care of the systemic cause for vision loss, which is diabetes. It will also require lifestyle management. It will also require some of the dietary advice. So you will require help of a nutritionist. But if we all have not worked together, I will focus on diabetic retinopathy. Diabetologist will take the patient into different setting and will think about it in a different perspective. Interprofessional education, when two or more professionals learn with each other, from each other, and about each other, it will improve collaboration among them and therefore the quality of care. And it will allow the interprofessional teams to work in cohesion to provide a holistic care to our patients. This graph shows you how the education system is so fragmented. If you focus on the upper half, you will see this is a typical program that are running in most low mid-income countries. But what we require is to have an interprofessional and trans-professional education so that they can work as a team to take care of the education, the healthcare needs. We also need to explore IT and technology for education. And Rabah talked about telemedicine, global education, but I think we need to create a knowledge management system using resources not just within the same institute or university, but rather taking help of resources available elsewhere also. We need to change pedagogy, and technology can help us. We need to embrace on the distance education and outreach education, and we can even embrace simulation and AI-based technologies in our education. We need to build national, regional, and global collaborations to address the educational need. Today, the expertise are not too many, and therefore, if they become resource not just for their own organization, but globally, that is going to help improve the quality of graduates coming out of. Expansion of academic center to academic system. Primary health care is completely missing from the curriculum of medical school and residency program. Most of the residents are trained in a setting of tertiary eye care with no connect to what happens in community. I think the training program should become a system where the residents are also given opportunity to work in a primary care, secondary care, and tertiary care to give them the holistic view of how their education is so important for community health. We should also build a more responsive and dynamic system, constantly review curricula, look into where the needs are, where the gaps are, and try to modify these curricula. These are particularly important in the low mid-income countries because new challenges keep creeping into our system. Let me talk about, in the last part, about the WHO competency framework. This document was published about 2 years earlier, and we were part of looking at the curriculum which is needed for the allied ophthalmic personnel. The idea is to convey the expected performance of different tiers of eye care workforce across all healthcare levels and enable quality care. Primarily also to integrate service delivery that meets the needs of the population. What it does is, the framework presents competencies and activities of an eye care workforce through 6 domains, which is practice, professionalism, learning and development, management and leadership, community advocacy, and evidence. I'll give you just an example of it. It gives you different level of competencies and activities, and therefore will be able to classify an allied ophthalmic personnel to one who is an expert in a particular area. So along that whole tier, you will be able to identify, based on the competency of the individual, at what level of healthcare system these workforce can be employed. It's a very beautifully done document which gives you what are the practice activities that we are looking at, and at different level, introductory level, intermediate level, advanced level, and at an expert level, what are different competencies that this individual should have. To conclude, the WHO competency framework is a very valuable tool for eye care. It provides insight into composition of workforce, competencies and skill, and it also facilitates education center to develop a standardized curriculum and assessment of competencies and behavior. Thank you very much for your kind attention.
Thank you. Thank you, Prashant, for a wonderful presentation. Actually, I think we is rightly, asked for the reforms. And the reason is the technology has gone so high and the curriculum is just at the same level. What if you see the curriculum of now National Medical Commission or the National Board of Examination, I happen to be there at both the places. So there is a big difference between that, Lots of things have emerged in the recent years, but those have not been incorporated in the curriculum. So I think there is a time, you rightly said, Prashant, I will talk to Radhika and ask her to liaison with the government and sit together, and definitely we should, make the innovations in the curriculum, and whatever is some modification is needed and all that. The other thing is that all these booklets, lots of booklets are prepared. I was one of the part of the WHO, package program for vitreoretinal diseases, and several other subspecialty was there. But the document don't reach the, the different institutes. So is in India also. As an advisor to Government of India, we made so many documents were there, but these documents are not reaching to the beneficiaries. So that is another thing, but of course that is not in our hand, but definitely it is in our hand that somebody should take the initiative in our country and make the reform in the curriculum. That is the need of the hour. So I think we'll go to the next. The next speaker is Dr. Rupesh, and Rupesh is ubiquitous, and everybody knows him. He's a widely traveled person. He's a professor in National University of Singapore. As a uveitis man, he just now told you, and several other qualities in him. He is also in the trauma, ocular trauma secretary, and now in international body and all that. Yes, Rupesh.
Thank you, Professor Azad, Professor Garg, and SAO and APO for giving me the opportunity to present at a bit of unfamiliar platform. So I thought, talking about the smart class, I should become smart. So this glasses is not presbyopic glasses. These are the glasses which some of your students will be wearing, and you will not know. These are the AI glasses, Facebook Meta AI glasses. with a charger there. So there is a charger, you can charge, and I can record, take photos, play Siri, play different things. So this is what, as Dr. Azad commented, the technology has advanced. The students have started adopting these new tools, and our curriculum or our platform is same. And one thing which Professor Garg pointed out, that we need to adopt technology as fast as possible. So we will see how technology can be integrated into the classrooms to make those classrooms smarter. Smarter is not by means of the ambience, but is by integrating technology. So, Azad, I don't speak that much on the education, but I'm just trying to understand, and with my technology knowledge a little bit, how it can help in the education platform. So first of all, we need to understand is the evolving landscape of education, which already quite nicely covered by Dr. Garg in his talk, and what are the opportunities for some of the technology for students, residents, fellow educators. So we'll put everyone in the same basket. We're not going to kind of divide what is there for students or residents separately and all, and what are the challenges which will be faced, and what are the future directions. So we talk about the technology. I think a lot to learn, and a lot of things which we learn from our colleagues and other things. So Industry 4.0, those who have been reading about technology, I did, in the COVID time, I did a program from Stanford about the digital transformation course, and it was a very tough to get that 80 points to get through that 1 year certification program. But one thing which I learned there is Industry 4.0, which is the fourth generation, the industry, the revolution, the fourth revolution of industry is about integration of technology, integration of digital thing into the manufacturing processes and the augmented and the automated processes which is happening. And these are different areas which we are working. So let's compare Industry 4.0 with Education 4.0 or the Classroom 4.0. So we start with Industry 1.0, which was about simple apprenticeship and informal education, or the education curriculum, which is the teacher-centered program. Then Industry 2.0 or Education 2.0 was lectures, examiners, structured medical education, but then a teacher-centered systematic approach to education. 3.0 to Education 3.0 is student-centric approach, where students started asking, and nowadays teachers are more careful of what student is going to ask them. But the 4.0, which I'm sure a lot of places have adopted, and my medical school in Singapore, LKC Medical School, has adopted quite significantly. And this is a slide borrowed from my dear friend Reddy, who is one of the lead of education in the medical school, is about the immersive learning and personalized adapted things. So around this topic, we divided the talk into four. What are the opportunities for the students and the residents? Just from some case examples, though there are many which I'm sure a lot of you will be knowing, but I just thought I'll just give few examples about. One is, of course, the web-based interactive simulators for students and the residents, which they can use, and they can do practice many things. So that's like virtual ophthalmology clinic, which has been set up by Sukar et al., and where there is an interaction and web-based teaching modules which have been developed, and which emphasizes on the steps of history taking, the clinical reasoning skills, and you can go through different modules. So I tried it because Dr. Azad asked me to deliver this talk. I thought, let me try it. And it was very interesting, some of those things which I learned, how it can be done and how it can enhance the education, because sometimes you don't have cases and all, and particularly during time of COVID, a lot of things converted into the web-based learning, and then for students have to resort to this thing. Second thing was this innovation by Cole et al. Called as iTelliGen, a web-based platform again. So I'm not able to access the website, but I'm trying to kind of talk to them, and is the website down and all. But again, it is about a platform, platform where you can use it. So first was about the history taking, medical examination. Now this is also about the fundus examination, and different modules are there, which will allow you to grade or allow you to pace your learning and education. So once again, these modules can be introduced to the residents or to the ophthalmology students, where they can learn and do different gradings, and it will tell you the scoring which you are doing and all. And they will also point out what are the mistake you are doing and where are the areas of improvement. Of course, this is not unfamiliar with anyone. Every single person, I think, coming here, and suddenly you will see the mails have become better, the write-up has become better and all. So we have been all using it, including myself. I've been using it quite a lot of a large language model, or chat GPT, which we call. So different platforms have been developed by many different people. This is an interesting platform called as iTeacher, a customized ChatGPT. So when I say customized, there are tools. The technology people know how the tools are there. We need to talk to them and how you can customize it to best fit. So what these people have done, they have many questions there, and they ask you A, B, C, D, and you ask, can you ask me as a student, can you ask me questions on, check my knowledge on diabetic macular edema? It will generate the questions for you, it will give you the options, then you have to select. So I say, okay, diabetic macular edema is this, A, B, C, D, I select A, it say answer is right, and these are the reasons for the answer to be right. So you imagine you don't have an expert medical attendant, but you want to train yourself. So if I want to learn oculoplasty, I don't know, I can't have access to Dr. Ganga, then I say, okay, can I know this about thing, and I want to know about pupil, then you can do that. So this is about second step. You have learned about the history, examination, and then about structured training, and you prepare yourself for exam. Of course, in the field of surgery, this has come up in a big way, and I'm glad to see there are many different indigenously developed prototypes which have been developed, and because these were very expensive, very difficult to afford, but now there are things which are coming up, and this has really increased the efficiency and also cut down on the PCR rates also significantly. One thing which I don't like for myself is the BCLS training. So in Singapore, everyone has to do the BCLS, and then it's all trained on this system, and you have to pass that when you can, this AI written, and every time I fail. So I need someone who can just do this for me, because it's just very difficult, because you can't cheat it. You have to actually do it to outcome it, and I just keep on failing it, because the breathing rate, how much you are compressing has to be the perfect, and if you do not do that, you just can't escape, because it's been already told. So you can't cheat some of the system. Of course, the deep learning for assessment of surgical competency. So you learn the surgery, and then there have been modules which are developed, which will give you a scoring about it, how you have done, and your project trajectory for rexes. You want a round rexes, something like, and you don't want an eccentric rexes, and you don't want a smaller rexes. You feed into the system that will give you exact scoring about how is your thing. And a lot of things can be done in your foot pedal, how much time you are pressing on the foot pedal, how is it shaking, and all those things can be done. So just, I've given you some examples of what can be done in the smart classroom in ophthalmology. I hope Dr. Azad have covered some of the points. And of course, in the vitreoretinal surgery, there are quite a number of things has been done. But of course, before Dr. Gar asked about what are the challenges which this can pose. So there are few challenges which we know, and I'm sure there will be a lot of other challenges. It can give you inaccuracy. So this morning also someone was speaking about, you need to know about what this AI is telling before you start adapting. So it is important that you rule out those hallucinations and don't get misled by the information which is giving, because for that you need to understand what it is happening. And it might not, lack of recency, it might not be the most up to date, but the things have been developed quite fast. Like ChatGPT 3.5 was there 2 years before, now suddenly it has exploded, and now it is coming ChatGPT 4.5 in between. So moment I start publishing a paper, and by the time I submit the paper, he said it's outdated. So how fast you can keep it? I'm sure by the time I go out of the conference room, there will be ChatGPT 5.0. So other thing is lack of interpretability. There are a lot of black boxes phenomena you can't explain. So you need, as a doctor, to explain. You can't just say, oh, my computer says that, therefore I'm giving you. My computer says that. No. As a doctor, a patient sitting in front, you need to give explainable. AI is therefore coming up in a big way. Ethical, safety concerns about data uploading. I am one of the editors for NPG Digital Medicine. Last time the editor wrote to me, please stop your reviewer from uploading the manuscript on the ChatGPT, because we can see the moment it is uploaded. So I got 2 warnings for some of my reviewer. He has even named the reviewer. This reviewer has done the entire review of the thing, but we don't know. And then there is a former editor-in-chief of JAMA, Professor Howard Bochner. He said he want things to go on the ChatGPT for a reviewer to review, and for this too. Of course, we are using it. So last, I'll conclude. The future directions is about adopting it in the structured training program, the formal curriculum program, about some of these tools very carefully, and it might be integrated in the field of medicine, and then we need to keep up to the pace. Thank you very much for your patient listening, and really glad for the opportunity.
Thank you, Rupesh. And how many of people are using AI to prepare their talks or content, or have some experience of using ChatGPT?
माइक यार, अरे कहाँ गया ये? बैठा रहता है लोग, निकलो. No, this is not good here. These guys are sitting, you know. They
We
come
used
late.
to make MCQs for our students. Very difficult.
कौन है
to
हॉल
make
मैनेजर
MCQs.
कौन है?
So you feed ChatGPT, it will give you a structure, and then we can kind of say, okay, this makes sense or doesn't make sense. So in that way, yes, I have used some.
Anyone else has any? No, I think Rupesh has very nicely covered the scope of AI for education purposes. But I think he has also given an insight into where are the challenges. AI is ultimately created by the type of data that you are feeding, type of resource that you are putting. And if you do not verify the output of ChatGPT or any of the AI tool, you may find yourself completely
तो देगा,
lost.
जो बोलता है.
So at this point
बकवास
of
मत
time,
करो.
it is important that we get educated about these emerging technologies and also understand the limitations so that we will be much wiser and will able to guide our students into how to use these technologies.
Very quickly, I'll make one more comment in continuation of what comment Dr. made by Dr. Garg is what we done with the ChatGPT for the UVitis. We developed an app called as UVitis with the A in that. It's not a spelling mistake. We deliberately integrated that, and we use some of the open source articles published and some of the PubMed articles, and we given the input that you pick up the information only from this, not from the redundant general Google search and all. So we wanted to cut down the noise in that. So it is very. Then I reached out to AIO office, went to the director of education there in the AIO, and I wanted to integrate their BCSC series, but I think they are developing themselves. They were not very open. So copyright is of course an issue. I can't just, I have the AO.
We are
digital
open.
thing. I can integrate.
We are open.
Yeah, I know you're given the book, but basically what we want to do is that then we did the same thing for trauma. So you need to develop for your own. Trauma, Ferenkun has given his permission. We use that book and we need a publisher permission, and then the information is only coming from those trusted things that you get. And then when you get that information, it also comes with this line has been picked up from this particular reference. So it comes with authentic information. Yeah.
Yeah. So it helps in doing things fast. But then I worry that, I haven't used it, but then since there's misinformation and then, inaccuracy is so high, would it waste our time just looking which one is right and which one is wrong? It's my concern since I haven't used it.
So this morning was a talk from my hospital R programming, and this morning I was moderating that session. So he said, if you are a coder, you are using it, you should know what it is talking. If you are not knowing what it is talking, then you should not be using it for.
Yes.
So if I use it for uveitis, I know what it is talking. I only use it for that. I'm not going to use it for corneal ulcer because that's not my domain. Okay, so that one I leave it because it will not. I will not know whether natamycin and then I give some other azithromycin in that. I probably will not know. That's where.
Thank you, Rupesh, and I will now like to invite the chair of this session, Dr. Rajvardhan Azad, and he will be speaking to all of us on use of social media platform in ophthalmic education. Doctor.
So, as we have discussed so far about the ophthalmic education, the level of ophthalmic education that we are having now, definitely better than what it was earlier. But the use of technology that has not kept pace with the development of the ophthalmic education. That was the reason why we devised this particular symposium. Now, you can see the figure. Almost 4.41 billion individuals are on social media in 2025. It's a big number, and which is easily accessible. And ophthalmology in our specialty is a visual science. And visual science and the media, media has got a very important portion of the vision, the vision. So considering that, it's very important to have the incorporation of the social media in our ophthalmic education. And we go down the evolution of social media. Earlier we had the blocks for the education of the patients. Later we had, now we have lots of these materials on Facebook and Twitter, and lots of material like information, public health campaigns, patient support. And then on YouTube, we have a lot of these videos, surgical videos are there, even the clinical, examination videos, investigation videos, and all these things are there. What is the importance of social media in ophthalmic education? One is the global reach. It has got a bigger reacher. It's a bigger reach. It is engages and has a lot of the potentiality of the collaboration. It facilitates interactive learning and of course the experience, collaboration among the peers. Now we are sitting here, and the engagement with experts in the ophthalmic field. And then another very important part of the social media in ophthalmic education is the real-time update. And you are doing something, some surgery, you can show on to the hall, to the audience. And I will mention name of my good friend Natarajan, who is very, savvy with this. Wherever he goes, he puts his this thing on the Facebook, and you can see what Natarajan is doing. If some lecture is going on in his hospital, Adit Jyot Hospital in Mumbai, you'll be able to see. So there are a couple of people, who are very savvy with this. We have, lots of these agencies are there, or organizations are there where you can get these, sources of this material which is there. And one of them is the American Academy of Ophthalmology. And ONE network, we all know, all of us have been there in American Academy of Ophthalmology. iWiki is another. And all these, have use of internet and web application as a platform for education, for case-based learning, for the clinical videos, and for the learning plans. And lots of other things like collaboration, like online encyclopedia, and other, forum for contribution to discuss or plan, policy and several other things. What is the anatomy of social media for ophthalmology? The first thing is, the anatomy is that content sharing. And the other thing is, the participation in the webinars, live surgeries, and virtual conferences. And in the media, social media, there was a revolution. And even in the commercial side, you must have seen a lot of these online platforms for, buying and selling, and something like that for education also. And that happened during the COVID-19, because we were all under house arrest, and we had no option but to go on to the social media. What are the types of approaches for use of social media? One is the curated educational content. The content which is going on there, the content should be well curated. It is well designed for the audience, for a particular audience, for the different level of audience. And it could be in the form of surgical videos, common signs and distincting images, then interactive quizzes. And it's now being used for a lot of these polls for, different subspecialty. You can find the surveys are there, monkey survey. So monkey survey, you can, for anything, like, vitreoretinal surgery, or for uveitis, or any other subspecialty, you can have a poll and you can have an opinion from the peers, and also an opinion from the audiences and from the students. And we all know about YouTube, and lots of people are now going on YouTube. I have seen, top people in different subspecialties. I know there's one Dr. Sareen here. He's a hepatologist, and his YouTube is very popular. So similarly, there are many other, experts are there, where the YouTube, becomes a very strong medium for not only for the specialist, but more so about the patients, about the awareness, about the management, about the knowledge about a particular disease, and I mean, you can go to the doctor and go for the investigations and other things. And Facebook. Recently, if you all open the Facebook, you must have seen, every day it is there, Honolulu conference, World Glaucoma Conference in Honolulu. I think you must have seen. So, I don't have Facebook. No, you don't have, but at least I see Facebook, and lots of other people are seeing Facebook. So if you put it there, some information, the information is far and wide. Lots of people see. So Facebook is another strong media for publicizing and for making people aware about a particular conference or about a particular kind of disease or whatever you want to call it. And Instagram. And Instagram is also another very important media. And this conduction of online conference and live surgeries. Live surgeries, have become, at least in India, I do not know. I don't think there is some issues are there. And therefore, maybe other places. But here in India, lots of people are using this online live surgeries. And another, importance of live surgery is that it fetches you good money from the trade people. So that is one of the reasons why, in many conferences, these live surgeries. But live surgery is useful also. You see the live surgery, because when you see on the, normal video and this thing, there you don't see the real time what is happening there. But live surgeries are definitely much more educative. So what are the challenges and limitations? The challenges and limitation is, first thing is the information overload. Too many things are there. So you are not able to think, what you have to pick up. But what Rupesh said, that you should know, if you want to find information about uveitis, you should know a little bit about uveitis. Then only you can catch that. So that is the, information overload. You take only those which you want. And another thing is the privacy and the data security. You have put so many things, and people can steal many things, You have something, there is no copyrights of that kind in Facebook or on Instagram. Somebody can pick up from there. Even otherwise, there are a lot of piracy is there on these platforms. And then there is a digital divide. So what are the solutions? The solution is quality control measures, one. And then there should be a training and education. And the third one is about the collaborative partnership. So that will help in promoting social media use. And then a lot of these ethical consideration is there. One is the professional conduct. The other one is the informed consent. And then there should be social media policies should be there, and to regulate all this. And these are the the compliances. There are, of course, there are some Health Insurance Portability and Accountability Act is there. And there is a copyright and intellectual property right is also there, and professional liability is also there. But these are all there, but in practicality, not many of these are applied or applicable. So that is the problem. So that's all, and thank you very much.
Thank you, Professor Ajad, for so eloquently talking about use of social media for education purposes. Are there any questions?
Yeah. So one question and two comment. One question. So basically, a comment maybe first about moderating the information upload on the social media. What is happening is people have gone freaking out, and too much of information they do. So for example, if I belong to an institution like my hospital, does the institution have any control, or should we, one is they should be all provided with the training about what to upload, what not to upload. which I think will help little bit, and we should conduct programs like this to say this is not supposed to be, and I'm sure people will still do that. But can institution put in some regulations? For example, can LVPI say a doctor that you're not supposed to be putting this? And I'm sure it happens in the parliament and government. Some people cannot do that, but can we take up some kind of a thing where there's so much of information that you get lost, and it's just that, and then sometimes people put in wrong information, patient photographs. So much of particularly the copyright article, people just upload the entire manuscript there, which is not right. And it's just that it's a matter of time when institutional and everyone will get affected. You're just supposed to upload an abstract or the title of it. But people upload so much of information. So somewhere, some control, how, I know it's very difficult, but I'm just trying to bring
No, I
up
think
point.
in our institute, we have an institute policy on use of social media, and every employee is governed by that policy. If at all the social media is to be used for patients or for any activity of the organization, it is screened through the communication department and then uploaded on the social media. So every organization has to come out with the policy that guide employees to use social media, particularly for things that are directly related to the organization. At their individual level, they have the full freedom of doing that. So that's how this is governed.
Now I invite Dr. Gangadhar Sundar. And Dr. Gangadhar is a oculoplasty surgeon. He is also a professor in National University of Singapore. And he is a prolific speaker. And of course, he has a lot of knowledge, and that's why he speaks. So I'll ask, he is also the General Secretary, Honorary Secretary for Asia Pacific Trauma Society. Sorry. President. He is now the president. I'm sorry, because I have been seeing these people, from the beginning. So I still consider him secretary, but of course now he is the president of Asia Pacific Ocular Trauma Society. So I present to you Dr. Gangadhar Sundar.
Thank you, Professor Azad. I know they can see at the bottom over there.
Yeah, I can see.
It's a memorable photograph because we started our journey on ophthalmic trauma. Remember, it's not ocular trauma, it's ophthalmic trauma. Because that's where I come in as an oculoplastic surgeon, because we believe the injuries affect all around the eye before it affects the eye. So we are true ophthalmologists, not just ocular specialists. So I'm going to give you a very basic, back to nuts and bolts, low-tech talk on fellowship beyond the classroom, beyond the curriculum, whether it's customizable or non-customizable program as such. So we all know about fellowship program. I heard yesterday that fellowship programs in India are not regulated, in the sense that it's not accredited. There's no certification national process where just because you're trained in LVP or Shankar Nethralaya RP Center, you're still an ophthalmologist. Am I correct? Yes. So but we continue to train our fellows into doing a lot of subspecialty work, and there are traditional specialties which are within the realm of that particular domain. That's about it. But then there are fellowships beyond that where it's multidisciplinary, pediatric neuro-ophthalmology, ophthalmic trauma, which we are very passionate about, where you have to cross-train between anterior segment and posterior segment, do a little bit of lid trauma as well. So that's very important. And those of us who do a lot of complex orbital work, our multidisciplinary work is not just with the fellow ophthalmologists, it's with the maxillofacial, ENT, plastics, and so on and so forth. That's how wide curriculums can be. And these are my disclosures based on some publications we've done in the past. But this slide is very, very important, because these are the fellows now we've trained over the past 20 years or so. And deliberately we put in all the maps, and the latest fellow we've trained and gone back is actually gone back to the West Bank. When I interviewed him for a fellowship, he was living in the United States. And I said, what's the point of training somebody from the United States? But when I realized what was his goal and dream was, this is before the war started, I said, wow, there's going to be a lot of potential, because there's a high birth rate, potential conflicts happening. Now this guy posts in my fellows network, which I'll show on later on, everyday cases of oncology and trauma, landed in the West Bank. Now he's seeing both the acute injuries and the chronic injuries, and from years ago, apart from the usual ophthalmological problem we have. So these fellowship trainings, which is what I think we all do, are both experiments and success stories, and shows a commitment that each one of us have, that the knowledge we have gained and experience we've gained over the years should not stop with us. That's why we should be very passionate about the fellowship. And my current fellow is now from Nigeria, another experiment, and the next fellow is going to be from Tunisia. Shows how far training can go, and I'll tell you how they are learning from each other. So these are the traditional models of training. There's the Indian model of basic diploma for a master's, national board training, for example. Then there's the British model of 3 + 3 years. North American is 1 + 3 years. Some people feel it's inadequate, but I think for a smart learner, that's good enough as well. But we are looking at what beyond residency. And that's where the various curriculum kind of comes in. An ICO curriculum has been quite popular in the past. Now we have Ophthalmology Foundation, which are coming up with some kind of curriculums as well. So here I put a very contradictory slide because Carl Golnick is no longer with ICO. But he was instrumental, along with Andy Lee, really coming up with this customizable curriculum. The first time ever they came up with a curriculum which is applicable across the world. And you can upscale or downscale based on what your local requirements are. These are globally applicable curricula. And it also has incorporated features where you're teaching the teachers of the residents and the fellows. And that's something that I think we should be, and those of you who think ophthalmology has got about 6 or 8 or 10 subspecialties, you can see the number of subspecialties where you have come up with customized curriculum itself. I was specifically involved in the curriculum development for ocular plastics, thanks to Santosh, who took the lead on this. And likewise, now you have these 4 or 5 disciplines where very detailed curriculum from year 1 to year 6 and 7 is also there. And the year 6 and 7 is where the fellowship curriculum is, where the expert level kind of comes in. At the same time, a year 1 guy should not be blocked from learning year 6 knowledge. Because patients don't read textbooks and say, I'm a resident 1 level pathology, corneal ulcer, so I should go to him. Whereas if I have a resident 5 level pathology, I should go to some other doctor. Patients have a disease. And every patient has level 1 to level 6 disease. And that's where the expertise kind of comes in. So when you compare our training to other professions, MBA degrees, for example, my daughter has one, there they will not let you do post-graduation without work experience. Whereas here we routinely fast-track our residents from year 1 to year 5. In fact, if you don't go into a residency program immediately after graduation, your parents will scold you. Likewise, if you don't go to your fellowship after your residency program, they say, you're not good enough. I think that mindset has to go. In fact, in my fellowship program, you have to have minimum 2 to 3 years of work experience as a general ophthalmologist, depending on wherever you're coming from. Before you come, that makes you a more complete human being and a professional as well. And these are things I think we need to really incorporate into our field as well. So what are the various fellowship models? Yes, we do a lot of one-on-one training. That's me on the top, supervising my fellow after the 6 months where they're a little more independent as well. You need to have both general and subspecialty training, which is what LVP does. They do general ophthalmology along with subspecialty work. I don't do that because I let them go somewhere else for a subspecialty basic level oculoplastic fellowship before they come to me, because in the 1 year they spend with me, they can learn at a higher level itself. And there are different levels of supervision. And if you look at the bottom right, are 2 of my fellows. One is a senior fellow, one is a junior fellow. The senior fellow guiding the junior fellow, because sometimes you learn from peers better than from your masters. And that lets the ego not come in the way of training education as well. And the older I get more short-tempered as well and impatient. So I'm actually now letting my senior fellow teach a junior fellow. Of course, me, I'm still there watching, making sure the right level of knowledge and expertise is really translating. So what are the training beyond the curriculum? That's where the role of subspecialties come in. APODS comes in, APVRS comes in. The role of visiting experts comes in. Surgical missions comes in. Fellow networks come in, and global education comes in. I'll quickly touch on each of this in the next few minutes. This is again Dr. Azad, the very historic photograph at my house. When we dreamed and conceptualized it's about time ophthalmic trauma needs a specialty. This is basically brains from different people coming together and trying to come together and try to form organizations and societies together. So we do conferences, we do a lot of case discussions, courses and master classes, which I think AIOS is an expert at. And COVID time taught us to do webinars itself. And so we were the very first, along with Farzad, who's over here, when the world shut down and all meetings came down to a slot. You can see the date over there, it's May of 2020. All meetings came to a halt when we realized there's platform now available to continue education. And the goal of this is not to train the Indian resident or Indian or Chinese ophthalmologists or the Belgian ophthalmologists, but parts of the world, Indonesia, Myanmar, Iran, or Africa, for example, who otherwise even could not travel before, they were deprived of knowledge and education. And that's where the webinars really came in and the societies took the lead on it. We did 6 courses of ophthalmic trauma during the ICO-WOC, which is cancelled. We took up the opportunity to teach on training and education itself. And if you look at the 10th anniversary program that we did, we made it a true global consortium, which means that we got speakers from every continent in the webinar format, not just North America or North India alone or North China alone, to share each other's perspective and helm. The keynote is given by none other than Tamara Fountain, who's a global ambassador for AAO now at this point of time, and she's a colleague of mine as well. And she gave us a global perspective with global experts speaking at the wedding as well. So 2 quick things about visiting experts. Yes, it is no longer just a Facebook live surgery conferences online, but these kind of experts coming to institutions inspire residents and fellows even more, not just stop with whatever ptosis and blepharoplasties you do. There's actually a Nobel laureate, Professor Sidney Brenner. He won the Nobel Prize for Physiology, where I made him give a talk. He was one of my lacrimal patients. He's passed now on. I gave him and asked him to give an inspirational talk to my residents and fellows and see where science was headed in the future. So being inspired, these leaders are very important. The next level is surgical missions. So whatever knowledge and technology you have in your practice is an ideal world. You have navigation, you have endoscope, this, that. But can you really extrapolate it to the real world? So we fly our residents and fellows to parts of the world which are needy of expertise in surgery. We screen patients on arrival 6 hours. Next 2 days, we are operating on the complex of cases. And the 4th day, we are seeing all the post-ops and making sure no disasters or revision has been done. And this now embeds a fellow in the rural area. So when they go back, they cannot say, I don't have this, I don't have that, therefore I cannot deliver care itself. So these are the kind of surgical missions that we used to do in the past. And we make it cross-disciplinary multi-speciality, which means not just an ophthalmologist. There's a head and neck, ENT, neurosurgery, maxillofacial. We see a whole gamut of pathologies. Then where we need to do specialty surgery on our own, we do it. Where we need to have multiple specialties come in. So you're enabling and empowering the local population, say that all I need is 2 or 3 or 4 human beings, not technology, and I can still deliver 90% of the care that we do for our need for our patients itself. Then the last 2 things are about fellowship networks, and this, I think, is very, very important. I have over here a group which is formed by my fellows. I didn't start the fellowship. They call them the United Sundar Siblings of NUH. And I thought this was going to be a good morning, good evening kind of chat room. No, actually, where is now going to these young junior fellows, freshly going out to practice, to figuring out where should I buy this instrument? What do I do with this foreign body? Is this metallic or not? Instead of asking me, because I'm going to scold them and say, I thought I taught you this or this. They ask their peers across in another part of the world who are already now practicing for 4 or 5 years, and they give them these answers. And I just now modulate this group and make sure they don't say anything terribly wrong. When they do something wrong, I just chip in. Otherwise, I let the fellows now teach other. And that's where the fellowship networks come in, and we do international courses at ICO-WOC. One of the guys right at the center is a fresh graduate fellow. I made him as a chair of the master program. So you're now empowering these fellows to do these things as well. And we have these global consortiums now, and we are about next week to start the first ever Pan-African Oculoplastics Consortium, where we're getting our past fellows and people around the world coming together to come up with something together. So in summary, I will probably stop right there saying that fellowship is ongoing. Knowledge learning, there's no limit to it. Now, I've now come to a point now I'm learning about new jugaad techniques from my old fellows who are making do with what they have rather than the theoretical things that we have as well. The future is technology-driven, we've heard it. We talked about AI-driven, and the future is with the youngsters. And gone are the days you put down the youngsters. Now actually you've got to encourage the youngsters to come up, because they now my kids know far more about all this than I do about all these things as well. And education has to be democratized. So talking about the copyright of journals, that's a very sensitive topic, because the journals are spending a lot of money. But in my opinion, what's the point of putting a scientific piece of which is inaccessible to the common man? So that's where I think sometimes it's okay to violate, cross the road, not at the zebra crossing, but actually regular wherever you need to do, but with a good intent in mind, that knowledge comes in as well. And I think we are now in the era of educational activism. All of us as subspecialty have to be not just educators, we have to be very activistic, hopefully not too radical, but every once in a while we have to do that as well. So summarize saying that learning never ends. There's formal education, which is what systems and countries and governments and organizations put together. There's informal education, which will be going as well. How many times have we gotten a wonderful, beautiful idea when you're in the toilet, chatting with a colleague on the next side, and he comes up with something and we end up coming together. So we should all probably come together, and we should probably be able to do more. Thank you very much.
Thanks, Professor Gangadhar. And any question?
United Sundar siblings. There is a professor in Colombia. She gave the term, she is an ocular immunologist or immunologist. You can imagine the term she has given. She said her fellows as lymphocytes. So she said, Rupesh, I'm sending my 2 lymphocytes to you, take care of them. So that's her term. Very interesting. I think, but you forget to put one of your favorite fellow. I was your first fellow, not oculoplasty, but I was a trauma fellow. You should have put myself as one of your siblings, United Sundar siblings. So I can be one of them. Thank you. Wonderful lecture.
Any other comment or any questions to? No, I think the point that Professor Gangadhar has made is very important. The fellowship does not mean a formal component of education. I think that is the beginning of a bonding between two individuals. But then they should really expand through the network of people who become part of it and then take the eye care to the next level. That can become a very good platform for learning from each other as well. So we should not lose sight of that. Whenever we talk of education, we usually remain restricted to the formal component of education, but we lose sight of that the mentorship goes on beyond the formal component, and there are many ways informal form of association is influencing the learning from each other. So thank you very much for so beautifully making that point. And if there are no more comments, we'll like to thank all the speakers. We will like to. There is a.
Dr. Prashant, this is regarding your talk. Simply changing the curriculum or modifying the curriculum actually is not going to change things much. No, there are so many ophthalmologists passing out every year. PG from AIMS or PGI or from LVP gets the same degree. A PG from a private medical college gets the same degree. Like you said, some of them without having ever done a cataract surgery during those 3 years. Now what is required actually more is that we have to force the NMC to specify the minimum equipment required in a medical colleges. There are medical colleges running and NMC doesn't specify what equipment is required in a medical college to run a postgraduate course. If you don't have the equipment, what do you teach them? And the second thing is there has to be a common standard examination. Unless you have that, simply having a curriculum on paper, there is everything. NMC has started what you said, exposure to rural areas. There is a program. Our residents go for 3 months to a district hospital. But what they do there, they are utilized for normal emergency duties. They've done nothing about ophthalm. They lose 3 months of their training given here and they come back. So these are the drawbacks which have to be covered first, and then ultimately the other things will come in.
Yeah, no, I think what I wanted to convey was more that the competencies with which a resident graduate has to be first determined, because we are not realizing that the competencies.
So, sorry to interrupt, like they have not even specified say minimum level of cataract surgery or something which a postgraduate should do or at least be exposed to different surgeries. And actually in the same way what you said, sir, social media now we are utilizing that where we don't have a concerned somebody trained in a concerned subspecialty or not enough work. There we are using in fact all this YouTube and all to show them that and at least teach them the procedures through.
No, the point is very well taken. I'm not, what I'm saying is that I think there is a time that instead of passing the exam as being the kind of certification, it should all, we should pay attention to what we want from our resident and are they coming out with those competencies or not. If they are not coming out, they should not be certified to become an ophthalmologist. So that's the crux that I want to bring in.
I don't think you've gotten a point. The problem is it is not the resident's fault. If the equipment is not there,
Yeah,
they are
I
not
got your
exposed
point.
to that.
Yes, I can
MNC
understand.
has to specify. You must
can-
have
I-
the
I
requisite
understand.
equipment for
Absolutely.
how many seats you have.
Actually, what is the problem is, there is a gap between the policy makers and the enforcement. There's a medical college and there is a National Medical Commission. So what medical commission is, policy is making, that is not going deep down, one. The other thing is, if it is going even, it is not being enforced. So there's so much of the intricacies are there. There is a central government, the health is a state subject, the medical education in state is because of the medical education department. So government sector, there is a problem, but not much problem in the private sector. And this is something very complex. So you are right, but this complexity is difficult to, take care of. Thank you.
Thank
We
you.
close
Thank you
the
very
session.
much. Yeah.
We already overstepped 5 minutes.